I think we can actually just start by introducing everybody and our panelists that we're so lucky to have here with us tonight. We have three dermatologists from all over the world with us tonight, and each of them has a different perspective on Cyspera from both clinical and practical reasons. So we're going to start off our discussion with Dr. Baruz Kazray, and he's going to discuss the science behind cysteamine isobionicamide technology and how it was discovered, how it's been used in practice, and some of the clinical aspects of it. And second, we are going to turn it over to Dr. Firas Al-Naimi, who is going to speak about how to use Cyspera in combination with energy-based devices. So this is going to be a lot of information about how this is going to realistically be used in your practice in combination therapy. And then lastly, we're going to hear from our lovely host, our lovely Italian dermatologist host, Dr. Michaela Zazaron, who is going to speak to how she has used this in her practice and some of the practicalities about implementing it into her practice as well. So I think that this is a good time to start, and I will ask Dr. Behrouz Kazare to join us and start our discussion. If you'd like to start by sharing your screen, Dr. Behrouz.
Of course.
Wonderful.
Thank you very much. So my name is Dr. Behrouz Kazray. I'm dermatologist, and I'm the Chief Scientific Officer of Scientist Company, Geneva, Switzerland. So I'm going to present you the new depigmenting agents, cysteamine and isobionicamide, and their combination of both these agents, and why we think that this is going to revolutionize the treatment of hyperpigmentary disorders. We know that today we have several skin depigmenting agents available. We have hydroquinone, we have Kligman's formula, we have tranexamic acid, oral, injectable, topical, we have kojic acid, arbutin, etc. The problem of skin depigmenting agents is that either they are rather effective, but they have safety issues such as hydroquinone and Kligman's formula. They have issues of carcinogenicity, mutagenicity about hydroquinone, skin atrophy, photosensitivity by Kligman's formula, and other maybe less important side effects, but still present side effects such as skin irritation, etc. Or they are rather safe, such as kojic acid or arbutin or vitamin C, but they are not very effective. So we are searching for agents which are effective and at the same time safe. And why do we think that we have such agents in our hands today? I'm going to present cysteamine. So what is cysteamine? Cysteamine is a natural molecule produced in our body. In 1966, for the first time, Professor Chavin injected cysteamine into black goldfish skin and found that this injection produces a significant skin depigmenting effect in black goldfish. 2 years later, other investigators applied cysteamine, 5% cysteamine, on the skin of black guinea pigs, and they found that 5% topical cysteamine produces skin depigmentation in guinea pigs. They compared it also with 5% hydroquinone, and they found that cysteamine is significantly more effective than hydroquinone when applied on guinea pig skin. The problem was that cysteamine was very unstable, and they could not stabilize it in their topical products. And that was the reason that cysteamine was never developed into topical depigmenting agents for decades. In 2010, we found a technology to stabilize cysteamine for the first time. So for the first time, we could put cysteamine in a topical product and to use it in human. Cysteamine, as I already said, is a natural molecule. It is present in our body. It is actively synthesized in our body. And it is present in kidneys, it is present in meat, in whatever you eat, in fact, there is some cysteamine present. And this is the antioxidant of human milk. When cysteamine is produced in our body, it is actively excreted into the milk. Maybe there are some protective effect for babies as an antioxidant. We do not know that exactly, but there is a reason that body has decided to excrete cysteamine in high concentrations in our milk. So what happens when we apply cysteamine into our skin? What happens in melanocytes? In fact, cysteamine is an inhibitor of tyrosinase. It inhibits the conversion of tyrosine to dopa and the conversion of dopa to dopaquinone. But not only that, it is also an inhibitor of peroxidase. Maybe you have heard less about peroxidase, the role of peroxidase in pigment synthesis, but peroxidase is an important enzyme in the last steps of melanin synthesis, where the conversion of dihydroxyindole and dihydroxyindole 2-carboxylic acid occurs for the conversion of these monomers to melanin polymer. In fact, peroxidase is also inhibited by cysteamine. Cysteamine also inhibits some non-enzymatic actions in the production of melanin. It inhibits Fenton-type reactions because it scavenges copper and iron ions and causes these ions to come out from the reaction mixture. And so tyrosine to dopa conversion is inhibited. This was about cysteamine. There is another molecule which is called isobionicamide that we have combined with cysteamine to increase its depigmenting activity. Now I'm going to present the second molecule and then data of the combination of these two molecules. So what is isobionicamide? Isobionicamide is a derivative of vitamin B3. This derivative of vitamin B3 is a potent skin depigmenting agent. In fact, we have niacinamide, picolinamide, and isobionicamide in this family of substances. If you compare the molecular structure of niacinamide, picolinamide, and isobionicamide, these three molecules, the upper part of the slide, if you compare them to resorcinol, catechol, and hydroquinone, to biphenolic agents, you can find that regarding the position of the active moieties, resorcinol is the counterpart of niacinamide because both active moieties, which are OH groups in resorcinol, are in meta position, and in niacinamide, which is the amide group and the nitrogen, again, they are placed in the meta position. So they are their counterparts. Picolinamide is the counterpart of catechol, and isobionicamide is the counterpart of hydroquinone. So in the phenolic group of substances, we know that hydroquinone depigmenting activity is more than that of catechol, and catechol depigmenting activity is more than resorcinol. So we hypothesized that probably the same could be true for pyridines, that isobionicamide could be more potent than picolinamide, and picolinamide could be more potent than niacinamide. Interestingly, we found exactly the same in their depigmenting activity in human skin. We applied these agents to the arm of human bodies, and we found that isobionicamide is more potent than picolinamide, and picolinamide more potent than niacinamide in producing skin depigmentation. So we began to search for the depigmenting mechanism of isobionicamide. How did it produce depigmentation? We found that it had a weak inhibitory effect on tyrosinase. Only 11% of tyrosinase activity was inhibited by isobionicamide. But there was another mechanism of action which was very interesting, and it was that isobionicamide was a potent inhibitor of melanosomal transfer, more potent than niacinamide. And so it had two mechanisms of action. Not only it reduced the production of melanin, but also it reduced the transfer of melanosomes from melanocytes to keratinocytes. So we wanted to have an additive effect. We wanted to combine isobionicamide with cysteamine to have some additive depigmenting action. What happened was much more interesting than that. When we added isobionicamide to cysteamine, we found a very high skin depigmenting activity that we could not explain until we did some in vitro tests and we tested their tyrosinase inhibiting activity when both of them were present in the reaction mixture. So where cysteamine alone was present, about 15% of tyrosinase activity was only inhibited. When isobionicamide was present, only 11% of tyrosinase activity was inhibited. But when both of them were present in the reaction mixture through an unknown mechanism, the tyrosinase activity was inhibited 6 times more. Around 67% of tyrosinase activity was inhibited when both these agents were present. So not only tyrosinase was very effectively inhibited, but also melanosomal transfer was inhibited by the combination of these two agents. We also found that isobionicamide not only inhibits melanin synthesis, but also exerts other interesting actions, such as anti-inflammatory property. We found that if we apply SLS, which is an agent which is very irritating during 24 hours on the arm of patients, and then we treat them with isobionicamide, already 30 minutes after the application of isobionicamide, we have a significant reduction in erythema, more than 40% reduction in erythema only after 30 minutes of application of isobionicamide. And after 72 hours, more than 85% of erythema was reduced. So not only this is a depigmenting agent, it's also an anti-inflammatory chemical. We also tested the anti-erythema effect of isobionicamide after UVB exposure. So what you see is the erythema production after UVB exposure, after 5 hours post-UVB irradiation. And we see that if after UVB exposure, isobionicamide is applied to the skin, erythema induced by UVB is significantly reduced. So it is an anti-inflammatory agent. It reduces the effect of UV. It is not shown here, but it also reduces pigmentation, which is produced by UVB. This is a case of mild acne and post-inflammatory hyperpigmentation only treated by isobionicamide. There is no cysteamine. Only isobionicamide has improved the complexion, has reduced post-inflammatory hyperpigmentation, and shows some slight anti-acne effect. This is what I see also in clinic. When I use isobionicamide even alone without cysteamine, I see that it does something for acne. This is another patient, no cysteamine, only isobionicamide. We see a skin lightening effect. We see that dark spots are a little bit reduced and the complexion is more beautiful. So isobionicamide has anti-inflammatory effect. It inhibits tyrosinase. It inhibits melanosomal transfer. And also we have some increase in epidermal cell turnover through the application of cysteamine. So these two agents, when they're put together, they have additive but also synergistic skin depigmenting actions. So we conducted a study for the evaluation of the skin depigmenting activity of cysteamine isobionicamide in melasma patients. This is a study that you can find in PubMed. It is published in the Journal of Drugs in Dermatology in 2024. It is done by Dr. Mukta Sachdev, who is a very well-known face in pigmentation. And she has done this independent trial on 3 groups of patients, 1 group treated by placebo, 1 group treated by the Kligman's formula by Triluma, and 1 group treated by the combination of cysteamine and isobionicamide. So we evaluated the depigmenting action at 4 weeks, 8 weeks, and 16 weeks of application. And patients were evaluated by MMC evaluation and also skin colorimetry. It was found that already after 4 weeks of application, the depigmenting action was visible in both groups. After 8 weeks of application, it was more prominent, but both groups showed the same depigmenting activity. And after 16 weeks, it was still more prominent, statistically significant, but no difference between the 2 groups. skin colorimetric studies and MAC score showed the same results. In fact, the onset of action of cysteamine isobionicamide was the same as Kligman's formula. This is very important because in the whole literature of dermatology, you can never find any agent, even medication, that has the same efficacy as that of Kligman formula. This is the first time that a topical product without hydroquinone, without corticosteroids, without retinoic acid shows the same onset of action and the same efficacy as the triple combination. And also patient satisfaction was significantly more for cysteamine isobionicamide combination compared to that of Kligman's formula. So in fact, we have a combination of natural products. Cysteamine is natural, isobionicamide is natural. Their efficacy when they are combined together is the same as Kligman's formula. You do not have any ochronosis, you do not have any skin atrophy, you do not have any photosensitivity, such as what you see with retinoic acid in the Kligman's formula. You don't have that in cysteamine isobionicamide combination. So you have a depigmenting product which is as effective as Kligman's formula without any side effects of the Kligman's formula, and you can continue it for a very long time. Kligman's formula cannot be applied for a long time because of those side effects. And cysteamine isobionicamide combination can be applied for very long time. In fact, you can use it for the intensive treatment, but also you can use it for the maintenance treatment. What I do is that I do 4, 5, 6 months of application every day until I have the maximum effect. And then I go to twice weekly application for the maintenance treatment of my patients. If you go to the literature, you can find several studies regarding the depigmenting activity of cysteamine alone, isobionicamide, their combination, sporadic case reports, and you can find many literature on these two agents. This is one of the cases of melasma and also lentigos before treatment, after 8 weeks of treatment, after only 12 weeks of treatment. Not only lesions have got much better, the skin complexion is also lighter. Another patient who was on Kligman's formula for more than 5 years, when she came to me, she had skin atrophy, she had the skin hyperpigmentation around melasma lesions, she had telangiectasia. I discontinued Kligman's formula. I put her on Cyspera, on cysteamine, and already after 4 months of application, skin atrophy was completely gone away. Telangiectasia were completely gone away. Hyperpigmentation was almost completely gone away. And the last photo on the right is the same patient after 3 years of application of this product. No side effect. Melasma lesions are completely away. No skin atrophy. So what Kligman's formula was not able to do after 3 years of application, cysteamine had already done in a few months. Another patient with post-inflammatory hyperpigmentation after 12 weeks of application of Cyspera. This is an interesting case. This is a case of acne only after 2 weeks of application of cysteamine isobionicamide combination. Not only we have the effect on post-inflammatory hyperpigmentation, but also acne lesions are gone away. I say that we see this effect in patients. We see that acne lesions tend to respond to cysteamine isobionicamide. What's the mechanism of action? Maybe the anti-inflammatory action of IBA, of isobionicamide, is involved in this therapeutic effect. We do not exactly know, but this is what we see in our patients. Acne patients, rosacea patients respond to Cyspera. This is only after 2 weeks of application. Usually anti-acne and especially depigmenting agents do not work after 2 weeks of application. It's very rare. Another patient, 16 weeks of application for the treatment of post-inflammatory hyperpigmentation, more than 90% of effect. A phototype 4 or 5, application for 4 weeks only 1 month. We see that the onset of action of Cyspera is very rapid. A patient with phototype 5 or even 6, only after 4 weeks of application, we see that most of these post-inflammatory hyperpigmentations are already gone away. Melasma patient only after 2 months of application. Lentigo patient only after 1.5 months. Periocular hyperpigmentation, you know that this is very tricky to treat, only after 12 weeks of application. Lip hyperpigmentation, very difficult to treat. We know that hair follicles are absent on the lips, so the penetration of skin depigmenting molecules is very difficult into the lips. Cyspera only after 19 days of application has produced this significant result. Lentigos, very difficult to treat by skin depigmenting agents. Usually we use physical modalities such as lasers or liquid nitrogen for their treatment. Actually, I don't even use depigmenting agents for that. This is a study which is already published, and this is a very good quality study. It is a randomized double-blind trial and has shown the significant efficacy of Cyspera for the treatment of solar lentigos already after 12 weeks of application. Scar, this is a hypertrophic scar, which is also hyperpigmented. We know that these scars are very difficult to treat because usually these pigmentations are like tattoos, and there is no hair follicles within these lesions, so molecules cannot penetrate into the lesion. We see the effect only after 4 weeks of application. Not only pigmentation is reduced, but also we have the impression that the thickness of this scar is also improved. So how do we use Cyspera? Usually you have two products. Original Plus, which is for sensitive skin, and Intensive, which is for normal skin. If you are in front of a person with sensitive skin, somebody who's very young, you opt for Original Plus. You begin for a few minutes of application. This is a short exposure product. Usually I begin with 3 minutes of application. I tell my patients to wash away the product after 3 minutes and then apply Boost, which contains isobionicamide. So first Original Plus, a few minutes, we wash it away, we apply Boost, and the patient goes to bed. Or you are not in front of a sensitive skin, you are in front of stubborn lesions, you can already begin with intensive product, intensive pigment corrector. The same protocol, you begin with 3 to 5 minutes. Little by little, you can increase it to 15 minutes of application. After that, you wash it away and you apply isobionicamide 5%, and the patient remains with it for the whole night. In fact, cysteamine is a short exposure product and isobionicamide is a long exposure product. That's why you have two products. First, cysteamine for a few minutes, and then isobionicamide for the whole night.
And Dr. Bruce, oh,
Please.
wonderful. That's
Please,
wonderful.
please.
I was going to keep us on track with time, but we're so lucky to have Dr. Bruce Kaz here with us. He's a renowned physician, dermatologist, and researcher whose passion for skin depigmentation concerns has led him to become one of the leaders in this field of study. He is the only person to successfully find a way to stabilize cysteamine, and you guys have heard it directly from him. So we are so lucky to have you here with us tonight, the father of cysteamine. Thank you so much. And I'm going to introduce our next speaker now, who we are so lucky to have to organize our webinar for us tonight. And oh, I'm sorry, we're going to go to our laser section next. So we're going to introduce Dr. Firas Al-Naimi, who is a highly experienced and skilled consultant dermatologist, Mohs and laser expert with nearly 20 years of experience in international standing, trained in some of the UK's top hospitals and fellowship trained in dermatologic surgery and lasers at St. Thomas Hospital in London, where he continued to work there as an honorary consultant for a number of years before moving into a full-time private practice. He has over 220 publications in dermatology and laser, including his own published book and 10 chapters, making him one of the most prolific and well-published consultant dermatologists in the UK. So I am going to turn it over to Dr. Firas, And Dr.
Thank
Farron, if
you.
you'd like to share your slides, thank you so much for being with us here tonight. Tell us about lasers and Cyspera.
Thank you. Thank you very much for the kind introduction. I believe you can see my slides, correct?
Yes, we
Yes.
can.
So good evening, dear colleagues. Well, it's a hard act to follow after Dr. Kasri, but I'll do my best. So we already heard that we have a problem with pigmentation, and we have a particular problem finding the right topical agent, because hydroquinone is a product that we're all familiar with, and it's a product that I have been using for many years, but I have also faced many challenges with it. So what I would like to say is, for those who have been using hydroquinone, we all agree that it's not something that we can use long term. And that is important because if we look at some of the conditions, such as melasma, we now know that melasma is a chronic disease, which means that I need to be confident in using something that is going to be safe to use, but moreover, long term. I'm going to talk about how I combine Cyspera, cysteamine with lasers. And the reason I'm saying this is because, again, when it comes to laser treatments, this is often a journey. This is not just a single treatment. There might be some conditions where one or two treatments would be sufficient, but often, particularly in patients with skin of color, they require a number of treatments spread over quite a period of time that can be several months. And I like to put my patients on a topical agent during that journey. And it will make me very nervous using things with steroids, such as the triple formula or hydroquinone. And this is why, when I came across cysteamine, I was really excited, and I have now experience with this product. So I'm going to talk about pre-treating with cysteamine before we choose lasers, but the same can apply to chemical peels. What have we learned over the years and how I do it? So this has already been discussed. When it comes to topical therapy, really worldwide, what I have noticed is I can divide the audience into two groups. You're either a hydroquinone user or a non-hydroquinone user. I personally am not a hydroquinone fan. It's also not licensed in the UK, and given the fact that we know that long-term usage is going to give us problems. We also heard from Dr. Kasri just earlier on that many of the other non-hydroquinone-based treatments have really disappointed us. We have topical tranexamic acids. We are unsure about the concentration, the formulation. There's often instability, irritation with some of the products, but that's not the case with cysteamine. So when I talk about lasers, particularly this is how I explain it to patients, because many patients will come to me with pigmentation and say, I have pigmentation and I want to fix it with a laser. If we look at pigments, that pigment can either be stable, solid. I will give you an example, a cafe au lait macule, a nevus of Ota. That is the type of pigment that is unlikely to be treated with topical agents alone, or may not respond at all. And those are the type of pigmentation that you can treat with a laser. But on the right-hand side, if you have this dynamic, ongoing, and a bit inflammatory or unstable pattern of pigment, where the patient might say, well, last week I was in the Maldives and it got worse, such as melasma, post-inflammatory hyperpigmentation. I can tell you that lasers can be very, very disappointing. And in some cases, it may actually make the condition worse. So we also know that the melanocyte becomes very active after laser treatments, and particularly in those patients with skin of color, so skin types 3 plus. Sometimes after the laser, the pigmentation gets worse, or they get additional pigmentation, which is laser-induced post-inflammatory hyperpigmentation. So the way to do it is to pre-treat, to stabilize the melanocyte, to stabilize the melanogenesis as much as we can, and try also and clear some of that pigment. And with the pre-treatment, I like a minimum of 2 weeks, but if the patient is compliant, and particularly with very strong pigmentation and patients with skin of color, I'd like them to be on a depigmenting agent for 4 weeks. So that is using cysteamine in this case, ideally a month before you will commence the laser treatments. But then after the laser treatment, we know that the skin is going to be inflamed and there is oxidative stress. That's where I want to keep them then on the cysteamine. This is just an example of a nevus of Ota. So this is type of pigmentation where you can use a laser, but you can also clearly see that this is a patients of Asian heritage, and often with nevus of Ota with lasers, we will require higher energies, which will then put this patient at risk of developing post-inflammatory hyperpigmentation secondary to the laser. And that is exactly what I mean by, even though the cysteamine in this case is not going to be used primarily for the purpose of the nevus of Ota, but it can reduce his risk of developing post-inflammatory hyperpigmentation from the laser treatments. If you look at this patient, this is a patient with lighter skin type with a cafe au lait macule. She will be at low risk. This patient you can just treat with a laser. So why combine? Well, we know that when we combine treatments, we optimize efficacy and patients get better results. This is just a fact. If you have patients with, often patients with melasma will have also some solar lentigos. So there is this diffuse dyspigmentation. So some of it is going to respond better to the topical treatment. This is why it makes sense to keep them on a topical treatment. And some of the pigment may require the additional help of the laser. And as I mentioned, you get the synergism and also reduce the risk of post-inflammatory hyperpigmentation. And patients also like that. Patients then are more engaged and more involved with the treatment if you tell them, and this is how I tell them, I have my own work to do, and you have your own homework to do. So if you look at a patient like this is a very classic patient who will come to me with pigments, in this case, lentigos, but often with these patients, I like to use Wood's lamp to look for hidden melasma. Often they will have hidden melasma. And this is where it goes wrong when you just use the laser blindly, particularly at higher energies, not checking for the hidden melasma. And then the patient after a month will come back and say, since you did the laser, it gets worse. So we know that if I will pre-treat, I am likely to have better results, potentially fewer laser sessions. The patient is going to be more satisfied. And certainly in this particular group who's at a higher risk of post-inflammatory hyperpigmentation, I can then safely reduce the risk of post-inflammatory hyperpigmentation. So really, my take-home message is very clear, and that is when I treat pigments, I like, and patients are seeking laser treatments or where there is an indication for this particular pigmentation to be treated with a laser, I like to combine. I like the patient to start on cysteamine or Cyspera for at least a month before the laser treatments. Now, I appreciate that sometimes that is impractical. Patients may want to start a bit sooner, but minimum 2 weeks, ideally 4 weeks, stop the day before, do the laser treatment, and then I just give them a very clear advice. As soon as the redness from the laser subsides, which may take anywhere from 1 to 5 days, they can then go back using the Cyspera. And then the question is, how long can they use the Cyspera? And this is exactly one of the points that I really liked about what my colleague, Dr. Kassari, just mentioned. That depends on as long as there is pigmentation, because this is a safe product. So this is where I had difficulties in the past when I was using hydroquinone, and the patient is coming maybe once every 4 to 6 weeks. Is the patient going to be on hydroquinone for a long time? That's when I will get nervous, and that's when potentially we get into trouble. So the advantage of cysteamine in this case, because it is not toxic to the melanocyte and it's safe, I keep the patients on it until they complete the treatment. So these are just some examples of patients who developed post-inflammatory hyperpigmentation after a laser without priming. So both of these patients, they came for something else. The lady on the left-hand side, she came for rejuvenation. These are not mine, by the way, but they were. But I did get involved with the treatment afterwards. And then the gentleman on the right-hand side had laser for acne scar on a small area as a test patch, and you can clearly see there is post-inflammatory hyperpigmentation, which really upsets the patients. Now, it may have been the right laser with the right parameters, but these type of patients with higher skin types are more prone and are at a higher risk of developing post-inflammatory hyperpigmentation. So in addition to sun protection, with sunblocks and photoprotection measures, pre-treatments, at least for a month, will reduce the risk of post-inflammatory hyperpigmentation. And we have a number of papers now that has shown that if you pre-treat, we do reduce that risk. If you get post-inflammatory hyperpigmentation, this is a nice systematic review. Lasers can help, but even in the article, and if you look at all the guidelines when it comes to the management of post-inflammatory hyperpigmentation and melasma, they all clearly mention that topical therapy remains the first-line treatment, and combination of energy-based devices or chemical peels with a topical therapy is advised. So regardless of whether we're going to choose an energy-based device modality or a chemical peel, topical therapy is always going to be part of that management. And to me, that topical therapy now is cysteamine because of its safety and efficacy. So lasers in post-inflammatory hyperpigmentation, they do work. That will be, if you are a laser user, that will be the 1064, so that's the 1064 nanometer wavelength. In the higher skin types, sometimes perhaps in the lighter skin types, you can shift to the 755 nanometer, would be the nanosecond or the picosecond. And the advantages also is that some of these lasers will have a fractional handpiece that can also give some rejuvenation. But if you use it alone, as I mentioned, sometimes there can be a risk. So even just using the laser for the management of post-inflammatory hyperpigmentation, patients with a higher skin type, patients who have not been pre-treated, the melanocyte is still active, the melanocyte actually gets activated. And there was a very nice paper from Asia showing that patients after the laser treatment have increased transepidermal water loss and increased melanocyte activity. And this is why we often hear from patients, particularly skin of color, who will say then the pigment got worse, and makes sense in that case to pre-treat. These are all the references, many references on the use of lasers in pigmentation. So we do know it works, but it works better if we combine treatments. This is a study that actually combines cysteamine cream. So this is exactly the cream that we are now today talking about. And this is in combination with a microsecond Nd:YAG. So that's a microsecond pulse duration. That is a pulse duration that is between the millisecond and the nanosecond. And there's one particular laser with this pulse duration that can be used for melasma. But again, I wouldn't recommend using it alone without pre-treatment and combination treatments. You can see some before and after images from the article. Another one, this is with a picosecond laser and cysteamine and isobionicamide, which was just explained. So we have a paper with the microsecond Nd:YAG, and we have a paper with a picosecond laser with cysteamine. And what I really like about this particular paper is you can see the skin color of the patient. So this is a high skin type. Many will be very nervous using a laser on this skin type, but living in London, which is a very diverse city, I have many patients of skin types 5 and 6. The picosecond laser will be the most appropriate, but again, those patients are at high risk of developing post-inflammatory hyperpigmentation, hence it makes perfect sense to combine that with cysteamine. These are just some of the commercially available different picosecond lasers with their different wavelengths. And as I mentioned, if we use lasers in pigmentation, one of the advantages that we can have is the additional benefit on the overall health of the skin, because we now, with many of these devices and the picosecond lasers, they come also with handpieces that can also help in rejuvenating the skin, so tightening the pores, firming up the skin, and the patient will have the added benefit of not just treating the pigment, but overall rejuvenation as well. This is a patient of mine with very challenging, difficult type of melasma. This melasma that often involves the mandibular areas. And she has tried everything. And you can already see she had developed some kind of depigmentation because of the Kligman formula that she used for a long time and causing also irritation. Now, in this case, if you're using a chemical peel or a laser, you will have to be using many sessions and with relative high fluences as well, which again can put her at risk. But by pre-treating her with cysteamine and keeping her on the cysteamine, you can see clearly that there is definite improvement. I'm going to continue treating her. But this has taken months, and it will likely continue to for further months. And that's why having the safety of cysteamine is really good. This is a patient who actually had a jellyfish sting, so I didn't know that it can cause profound post-inflammatory hyperpigmentation. This is just an example of pre-treatment with cysteamine and then a session with a pico laser and to continue to treat. What is interesting about her is she actually was booked for the second laser treatment, but then phoned up and said, well, I can see that the cream is helping and it's lightening it up. Can I just continue with the cream and basically save money and not come for the next laser treatments? And that's exactly, the right way of doing it. So in this case, you can clearly see by just combining the treatments, I could ensure that the post-inflammatory hyperpigmentation is not going to worsen after the laser, but also she will have synergistic effects. In other patients, you can see the higher skin type. You can see some melasma and some lentigos. She specifically wanted the laser treatment. She's been fed up using just creams. Some chemical peels didn't help in the past with another doctor. But if you just jump in this case with a laser without pre-treating the skin, you're going to run into trouble. So in this case, pre-treated with a cysteamine, having the laser treatment, and to continue using the cysteamine. And then she will ask, how long can I use the cream for? Well, as long as she wants and as long as there's pigmentation. That is the advantage. So in short, I've come to the end. The take-home message is very straightforward and clear, and that is ideally pre-treat for a minimum of 2 weeks, ideally 4 weeks, for those patients who you are going to treat with a laser. I would extend that to chemical peels. Stop the day before, and then restart and continue as soon as the erythema, the redness from the laser subsides, which is anyway from 1 to 5 days, and they can continue using that regimen until the next laser treatment. Thank you for listening.
That is wonderful. Thank you so much for your wealth of knowledge that you shared with us today, to combine Cyspera with lasers, which is a really important part of practicing in an aesthetic practice. And finally, now will be the time for me to introduce Dr. Michaela Zazaron, who obtained her diploma of medicine and surgery at the University of Padua, where she completed a fellowship in molecular biology. She furthered her studies with 4 years diploma at the School of Aesthetic Medicine Valle in Bologna and had obtained a master in trichology in the University of Florence. She completed a master's diploma program in anatomy of the facial superficial structures at the University of Nice in France. And in 2018, she attended IFFASS fellowship in Seoul on mini invasive facial rejuvenation and lifting. A really interesting set of dynamic information here. And thank you so much for organizing our call and being with us today.
So thank you for the presentation, and thanks to all the colleagues for the very impressive scientific background shared to us. It's my pleasure, and I thank you, the company, for inviting me to share my experience so far with Cyspera and why I think it is very worth it to include it in our armamentarium to make our patient even more satisfied than ever. Cyspera portfolio is easy. We have only 3 references to be combined to set an overall protocol. And this can really help considering the compliance of the patient, and also can help to address and cover the issues for patient who do not have a very high budget. The 3 references we can work with are Cyspera Original Plus, as Dr. Burrows already shown us, made with 5% of cysteamine and 5% of isobionicamide. We have then Cyspera Intensive, which has a higher concentration of cysteamine, 7%, and 3% of isobionicamide. And then we have the Boost, who has the isobionicamide 5%, and then other depigmentating active, retinol, vitamin C, and dexpanthenol, for example. The protocol is very easy to be set and explained to the patient. This arises very much the compliance of the patient himself. we should combine Cyspera Original 1 or Cyspera Intensive according to the sensitivity of the skin of our patient and to the severity of the pigmentation. So we have to decide if starting use Original 1 or Intensive, combining it with the boost. Cyspera has a high efficacy, as we saw from Dr. Barrow's presentation, and as it is, published, well-known, published in the literature right now. But according to me, one very key point is about safety. Cyspera has no photosensitivity, can be used in summer for maintaining and improving the treatment of the pigmentation, is safe for being used in all skin types. In Italy, we deal with the Fitzpatrick 1, 2, 3, 4, not with 5 and 6 skin types, but it is important to know that we can easily and safely use it on all skin type. There is no carcinogenic or mutagenic or cytotoxic effect. And it is suitable, as we saw from the clinical cases before, even for body application. It can be used and combined with other procedure, not only as an improvement after laser, chemical peels, or microneedling procedures, but as we saw from Dr. Firas, as a pre-treatment, a primer, in order to improve the outcome of the treatment and also to avoid some side effect. It can be used in not only on the spot, but we set the protocol making the patient use it in all the area involved by the pigmentation, because there is no risk of halo or graying effect and no hypo or hyperpigmentation. So these are, as you can easily see, one of the most crucial points that we can fix by using Cyspera. And regarding the easiness of the protocol, it's very, very easy to be set by our patient, even those ones who do not like very much having complex skincare programs to follow every day. The application is a short contact therapy, 15 minutes daily application on the area to be treated on non-washed skin. I suggest my patient to apply it in the very morning, immediately after they wake up, before washing the face, or before washing the face before going to bed, because this is one of the tips we have to remind, that the product has to be applied on non-washed skin. Then we can leave the product up to 15 minutes on the area, and we can gently rinse it off with a neutralizer or a gentle cleanser. After that, we add the application of the boost, which is very welcomed by the patient, for example, as a night cream. So it's very easy protocol. The only recommendation is about sensitive skin, just to go with gradual progressive application, starting, for example, as Dr. Barrow said, with 3 minutes application and going up to 15. And then, of course, we have to prescribe a very high SPF cream to be applied every day. But if we deal with the hyperpigmentation, we know that, of course, this is a must. One of the most interesting fact about Cyspera is the quick response, even in terms of skin texture, skin glowing, and skin quality. This is the very first patient of mine after the 10 weeks of therapy with the Cyspera Original applied in a thin layer, 2 pumps per day, 15 minutes application, and then with the boost used in the evening, and of course the SPF. She was very satisfied, not only because of the improvement of the pigmentation after 10 weeks, but also because of the skin quality. And this is due to the antioxidant and maybe anti-inflammatory even action of Cyspera, as the publication show us. independent clinical study had proven that a visible radiance improvement is come from 78% of users, and the results and the safety of the application of Cyspera is also regarding sensitive and intimate areas. This is true for original one, and we have a short gynecologist study evaluation on 11 subjects, applying 1 pump of Cyspera in intimate area without any case of irritation or side effect. And this is an issue that we could cover because we have increasingly demanding of aesthetic medicine on the intimate area. So it's very easy to prescribe and very safe again to apply. The same result, even higher regarding improvement of skin texture and healthier looking skin for patient using Cyspera Intensive and Cyspera Boost. I'd like to spend one word for this product, which is really, really very welcomed by the patient. In my clinical practice, I consider it as really a substitute for a night serum or a night cream because it is very comfortable, the texture is very nice, and the patients love using it. Regarding combination of protocols, we saw the combination and the safety of that with lasers procedures, but also with chemical peel and microneedling, hydrofacial or whatever. The only safety rule is just to wait for the redness, the inflammation period after the treatment to fade away, to start with the application of Cyspera. But as we saw before, Cyspera can be used just until the day before the treatment. We can combine Cyspera even with oral products such as retinoids or tranexamic acid, maybe managing the frequency of application regarding the tolerance of the skin. And we can have a little bit of expertise combining it with the retinoids, decreasing the frequency of application, but definitely this is a therapy that can really help even in combination with other topical drugs and pharmacies. Regarding the duration of the treatment, until the benefit of the skin is high. In my experience, I have been using Cyspera for 3 months, and because of the fact that there is no photosensitivity, my patients are willing to go on with the therapy even during summer. And you know, with the using of retinoids or hydroquinone, this is not even possible. And so I found that the easiness, the efficacy, and the safety of the protocol really helped my clinical practice. And I think that after this webinar, thanks to our colleagues, we will be all, more than convinced to include it in our portfolio.
Thank you so much. This was so wonderful. I think the practical application and how to build this into your practice and the reasons for using this in your practice are really important. I think we're sort of just on time. Maybe we'll go over 5 minutes depending on if we have more questions. Thank you, Dr. Zazaran, for your informative information there, and to all of our panelists here today, because there's so many different reasons for using Cyspera in the practice. So there is a chat for our attendees, which you can see in the button below, and you can type into the chat if you have any questions, either in Italian or in English, and we'll be happy to answer those. And while you guys are thinking about if you have any questions, the one thing that I wanted to ask to our panelists together as a group, because I think it's an important aspect of treating hyperpigmentation as a clinician, is, how do you manage patients' expectations? Like, do you ever see 100% of the pigmentation cleared in your patients, whether you're doing lasers or combination treatments or Cyspera? I just want to see how you doctors manage expectations for your patients. And just make sure to unmute, and you guys are welcome to speak together as a group or chime in.
Well, maybe I can start. I mean, I guess that depends partly on the diagnosis and whether the patient is treatment naive or has had a treatment before. There are some, if someone is relatively young with no extensive sun damage and is only worried about one simple lentigo, then usually the expectations will be high, and I will have that, confidence to explain to the patients. But often what I see in practice is that I get the patients who have already failed on other treatments. They have chronic pigmentation, deep dermal melasma. So I usually tell them very honestly that, complete clearance, that's not going to be possible, and that's going to be very, very difficult. But what we're looking for is, as much as possible reduction. And the one thing I learned from many other colleagues is that the patient will going to have to do their homework as well. It is something, it's going to have to be incorporated into the lifestyle of the patient. So I don't say, I actually tend to lower the expectation, try to over deliver, and being very realistic. So I don't tell them it will be a complete clearance, and I'll tell them it will take a long time. I usually, I do agree that you can sometimes see clearance relatively quickly, maybe as soon as 2 weeks. But just to manage expectations, I tell my patients to wait for at least a month before they will see anything. So I just like to
That's
have a
great.
month as a follow-up.
I think that's really great. And Dr. Baruz, you've had so much experience with Cyspera in your practice and other procedures as well. And how do you manage the patients? Do they ever get 100%? Does pigment come back after the procedures? How do you handle that?
No, of course, 100% improvement happens, but you never know in whom. So you cannot promise that to anybody. And of course, you should not overpromise. Even if we know that first results can happen after 2-3 weeks, I never say that. I tell before 4 weeks, before 6 weeks, you do not see anything. When they come back, they're very happy. They say, already after 2 weeks, I saw something. No, but if you overpromise, you will hear the opposite. They would come, they said, sometimes you say after 4 weeks you see something, they would believe that after 4 weeks melasma has gone away. No, they would expect something else. So it's better to under-promise a little bit, not to disappoint them, but to under-promise a little bit and let them discover the efficacy themselves.
And then maybe if I can add something, totally agree, of course, but this is a journey, as we said before, and we should even warn the patient that sometimes we could change or adjust a little bit our protocol, starting in a way and then adjusting according to the clinical improvement in order to keep them engaged. But regarding, the combination treatment with Cyspera, I find that it really changed dramatically the compliance with my patient, because I use a lot of hydroquinone and steroids and retinoids. And this is really a game changer. Even in Italy, when most of the patients like sunbathe a lot, and because of the lifestyle, you are not always sure that they follow your instructions, etc. So I really think it improved a lot, even the easiness of the prescription.
That's great. And then we do have just one question that came through, which is just regarding like the comparison of using Cyspera, which is an at-home treatment, to the use of a product such as a peel like Cosmelan, which is a peel system. Any of the doctors can answer this. Do you think of them as the same? Do you use them in combination? Do you have some patients that don't like peels that will do Cyspera, or would you combine them?
I use a lot of chemical peels. I use also that one mentioned, and I think Cyspera approach is very, easy to be prescribed as maintenance protocol, but also for average low budget patient, because this is an issue we have in Italy. Sometimes the cost of the overall laser treatment protocol or overall peeling, the most used in the world for the melasma, is not for everybody. And sometimes you can really offer a starting therapy for the patient, engage her, and then when you have the alliance of the patient, you can really go into and start with other procedures. So I think there is no exclusion, but a combination, even a psychological one, together with the clinical one we saw with Dr. Firas and Dr. Burrows.
Yeah, if
Yeah.
I may add, I totally agree. I think what I always tell patients is that if you are going to combine the treatments and if you are going to be compliant and consistent with the home care treatment, you may require fewer number of laser treatments or chemical peels, which ultimately means the patient's going to save money, which is true. And I could tell them, for example, you may require, you know, less than 5 sessions in that case, which if that is how much a laser treatment will cost, that's how much you can actually save. And often I find that this conversation will further motivate the patients because patients don't want to spend a lot of time endlessly on treatment. So I usually come at it from that angle. Also, the other thing that I have noticed compared to many other, because we have so many treatments available, and sometimes patients get confused as well. Patients seem to like the fact that you explain very clearly it's a short contact treatment. And with that, they think, okay, so this is something that is stronger. If I leave it on for longer, that's not the way to do it. Because they're used to just using creams, and sometimes they'll say, well, I used this twice a day. It was meant to be once a day. I can't see any difference. So the simple fact that I explain to patients, you build it up with a tolerance, 5 minutes, 10 minutes, 15 minutes, short application, then you neutralize it. That gets the patients a bit more motivated, and the patient seems to just think that, okay, this is a different treatment from just any other cream that I will leave it on, because they often have, when they come to me, they have lost faith in a topical treatment. So when I start talking about a topical treatment, many of them will just say, well, nothing works. But I find that if I explain to them it's short contact, it's just building it up for a maximum of 15 minutes, you get a very different interaction with the patient. That's my experience. I don't know about my colleagues.
Dr. Bruce, maybe you have some insight.
Yeah, I think that everything has been already said by my two colleagues. I want just to add something which is very important about Cyspera. I think that a differentiating point about Cyspera is that you can continue it lifelong for maintenance therapy. The problem with depigmenting agent is not that we do not have any effective depigmenting agent. We have oral tranexamic acid, for example. It's very effective. But how long you can use it? I usually use it for a few months, 6 months, but I'm not going to use it a lifelong because it will cause maybe thrombosis and the patient might die for that. And so you should have something which is effective, but also can be used lifelong because melasma is a lifelong disease. Like hypertension, you cannot just stop the treatment, you should continue. So this is the first time we have something which is effective and you can use it the whole life. This is, I think, a very important differentiating point. You can combine it, of course, with different treatments, etc., to increase the efficacy during the attack phase, but after that, maintenance therapy for long.
I think that's wonderful. I think that we are out of time. I don't see any other questions. So I just want to thank everybody, all of our attendees for being here in your evening in Italy and elsewhere. Thank you to our doctors, Dr. Baruz Kazray, Dr. Michaela Zazaran, Dr. Faris El Naimi for being here with us tonight. I am just going to share the last slide here, which is going to give you some contact information in case you do have any further questions for us, for the company, for Dr. Kazray. This is us, and thank you everyone for joining, and we hope that you have a wonderful rest of your evening. Ciao tutti.
Ciao, grazie. Thank you.
Ciao.
Thank you.
Thank you.